Hi, we'll be talking about the management of lateral border of tongue carcinoma, which is a part of the anterior two-third of the tongue and a stage of T1, N0, M0, uh, TNM staging carcinoma. To see the other videos, you can see this link, and a lot of other videos are also available on this particular link. So, we're talking about the management. So, for management of any disease, we talk about the investigations as well as the treatments. So, for any oral malignancies, there are certain things that has to be done properly because those things are very important for the ultimate management of the patient. The first thing that you can see over here is a proper head and neck examination. This head and neck examination is important because there can be other synchronous disease tumors present in the oral cavity along with the carcinoma of the lateral border of the tongue. And a proper head and neck examination, including a proper oral examination, is important because of the TNM staging. Now, most of the time, while managing the patient, you will be taking you're going to take the biopsy. So, before taking biopsy, it's very important that you don't uh, change the architecture of the the lesion which is already present. For that particular reason, it's important that uh, a proper TNM staging is done, and this TNM staging includes the tumor size, and it's a clinical staging, and for which you have to do a proper oral examination. Now that's the first thing. After TNM staging, if you see if any associated lymph nodes are involved in case of a tongue malignancy or in case of a tongue growth, then we would like you would like to do an FNAC, fine needle aspiration cytology, for which you would like to collect the sample and put it on a glass slide, fix it, and then send it to a pathologist for further evaluation to see whether it's really a malignancy or it may be or an infective cause or whatever. Then after you have localized the growth, you want to do an incisional biopsy. That is, you don't take out the entire mass as such, you just take out a part of a mass to send it for histopathological examination. Okay, for other investigations that can be done is an MRI or CT scan. Here you can see a CT scan of a tongue lesion, which it shows enhancing lesion which does not cross the midline. So there's a tongue lesion over here, and the CT scan also will help us, or MRI scan will also help us to visualize any uh, invasion into the surrounding structure. Okay, that is important for your surgical planning. Now, don't forget to do a chest X-ray in case of oral malignancy, because there can be primary bronchial carcinoma which is present. In majority of the patient, you will find a primary bronchial carcinoma. In case the tongue malignancy is squamous cell carcinoma, most of the cases are squamous cell carcinoma. So you should not exclude a chest X-ray. Okay, and there's a dental evaluation which is important before starting radiotherapy, because in case of any dental caries which are already present after radiotherapy, what happens, the blood supply is reduced, so there's chance that the infection can spread. There can be mucous membrane infections. So if any damaged tooth is present or dental caries are present, it's important to rectify that situation before you actually start the patient on radiotherapy. Okay, now sometimes what happens, the treating surgeon suspects that there is a possibility that there can be malignancy in other areas also associated with an oral malignancy, and these areas are very difficult to assess clinically, so you have to take the help of something called as triple endoscopy. Triple endoscopy involves the usage of rigid bronchoscopy. Read the line over here. It's usage of rigid bronchoscopy, that is you're visualizing the bronchus. Esophagoscopy, that is you're visualizing the esophagus. And laryngoscopy, or you're visualizing the larynx. And sequentially, and in case of any suspicious lesion, you have to take a biopsy. And most of the time because it's tongue carcinoma, after the treatment person can have difficulty in its speech, so you have to counsel the patient about speech therapy, speech loss. And you can tell the patient that there is something called a speech therapy which will help him to talk in case he develops a slurry speech post radiotherapy or surgery. And it's also important to counsel the patient about smoking cessation and cessation of tobacco chewing. So we are talking about stage 1, T1, N0, M0 over here. So T1, N0, M0 is stage 1 oral tongue cancer. Stage 1 tongue cancer can be treated by surgery or radiotherapy or a combination of both. But whichever, based on desired outcome. If a person wishes to speak, you say that you, as a surgeon, you decide that you don't want to, you know, uh, uh, take off the tongue, you don't want to excise the lesion, rather you go for a the option of radiotherapy. But if the person says I'm fine, I don't want any risks, then the surgeon can actually go ahead and do an excision. Okay, so based upon what the patient wants, what the outcome that the patient desires, or sometimes you and the patient as a group desire, you choose the therapy based on that. So in case but surgery is always preferred and for stage 1. And in case the patient wants to go for surgery, then a wide local excision can be done with 1 centimeter of clear margin. It's important to have 1 centimeter of clear margin. Next, sometimes the surgeons this says that okay, we might need to do an additional neck dissection along with the wide local excision. So some surgeons says that we may not do. Okay, so what are the factors which decides whether an additional neck dissection needs to be done or not? Okay, so first, inside the blue box you have this follow-up plan. That means you're not doing any neck dissection, you have just done a wide local excision, and you have kept the patient for follow-up to see how the patient progresses. See, that is the reason why you keep the patient for follow-up, is because there's a very low chance of metastasis. That is, you have less than 4 millimeter in size, in diameter of the diameter of the tumor is less than 4 millimeters, so there is low risk of metastasis. As the larger size of the tumor makes it more risky for metastasis. If the tumor is well differentiated after your histopathological study, so less chance of metastasis. If no palpable lymph nodes on clinical examination, and if satisfactory clinical examination has been performed and you see that everything looks fine, and ultrasound also you have done and it's negative, then you can say okay, fine, it looks like a low risk situation, so we can go ahead with follow-up rather than a neck dissection. Okay, you don't want to do neck dissection, you don't want to remove lymph nodes. Okay, but sometimes as a surgeon you would like to do, okay, I want to do, and you'd like to do an elective neck dissection. You'd say that okay, I want to do an elective neck dissection. So the situations where you choose elective neck dissection, if tumor is greater than 4 millimeter in size, that is a slightly larger tumor compared to a low risk tumor. Okay, unreliable follow-up, when the patient says okay fine, I might not follow up. Okay, or you think that okay fine, the patient might not follow up, then you need, because you need to constantly keep checking the patient whether lymph node metastasis has developed or not. Or if the patient has a short neck in which you have not it was very difficult to do clinical examination, and it was not satisfactory in that case. There's another option called as elective irradiation. Elective radiation irradiation is that when you're choosing primarily, when you choose primarily the radiotherapy as the the treatment of choice. In that case, you want to do a radiotherapy and you don't want to irradiate the neck again. You don't want to do surgical excision of neck lymph nodes. So in that case, you give, with radiotherapy, you also give an additional elective irradiation to the neck nodes. That is when the primary tumor is treated by radiotherapy. So what are the lymph nodes that are removed? Level 1, 2 and 3 lymph nodes are usually removed. Okay. Now, surgery and radiotherapy, what are the advantages and disadvantages? And okay, so advantage of surgery short time, and so better compliance. That is, it does not take a long time. For radiotherapy, the patient needs to keep coming again and again. See over here on the right side, you have got radiotherapy requires at least 6 weeks of treatment. So patient needs to keep coming again and again, and that can reduce compliance. Okay, and in surgery you have a specimen which is available for histopathological examination. A histopathological examination is very important because that will give you a definitive diagnosis, but in radiotherapy you don't have no such uh, you have no such option. It helps in planning adjuvant treatment. That is what about that is that it goes hand in hand with histopathological examination. When you have got histopathological examination, you will find that the variety is not just common cell carcinoma, it is something deadlier. In that case, you might need to give a chemotherapy regimen. Okay, that is adjuvant treatment. No radiation. Sequelae, radiation comes with a lot of disadvantages, like can give rise to osteonecrosis, osteonecrosis of mandible, which goes with radiotherapy. Over here you can see the mandible bone is exposed, the mucosa is kind of dissolved. It can give rise to oral mucositis, radiation therapy, which is not, such kind of problems are not present with surgery. What about the disadvantages? There is a tissue and functional loss. Okay, sometimes that if the tongue tip is not gone, if tongue tip is there, then the patient will not have difficulty talking in speech. But the tongue tip is gone, then the patient finds it very difficult to actually talk. Okay, and after surgery, usually the patient has speech problems. Okay, it can be rectified with speech therapy, but it's slightly more difficult. But radiotherapy, the patient will still be able to talk. It's more disfigurement because you're giving incisions or scars, infection, bleeding chances are high, and there can be mortality. And when you're doing, if you're doing neck dissections, can have complications related to neck lymph node dissections. Okay, now radiotherapy. On the right side, you see provide better functional result with superior speech and swallowing. Okay, swallowing is also affected in case of surgery, but your speech and swallowing is not affected. Disadvantages of altered taste, xerostomia, and the protracted nature of the treatment course. Okay, xerostomia is the altered taste, and sometimes mucositis can be there. It's extremely painful condition. It requires at least 6 weeks of treatment, so less compliance. Osteonecrosis of mandible, as you can see in the picture. But there are some newer therapies like brachytherapy and immune IMRT, which focuses on a certain area. It reduces the above side effects. So, but these are costlier compared to normal radiotherapy. Thank you. Please comment and like the video, and go to the other uh, web page to see more of my videos.